Hello, hello and welcome to day 4 of Migraine Headache Awareness Week. My name is Nick Grundy and I'll be your host for tonight's session, which is on other types of disabling headache with Dr. Katherine Spira. So Migraine Headache Australia is a division of the Brain Foundation and our mission is threefold. So firstly, we focus on providing trustworthy and reliable information. So that can be the articles on our website or resources such as this webinar. Secondly, funding research. So we aim to fund at least one research grant into headache and migraine every year in the Brain Foundation Research Grant Program. And thirdly, we advocate and support people living with migraine and headache disorders. Next, we've been highlighting a different part of our advocacy events and media every day this week. And today we're focusing on the two in the top right corner. So on the left, we have our director, Carl Cincinnato, speaking on ABC Live News with reporter Ros Childs. And they did an interview where he talked about the impact of migraine, the stigma that people face, and the kind of lack of research and how overlooked it is in both the medical community and wider society. And on the right, we have an article by ABC reporter Tamara Uden. And we provided comment for that article, and she opened up about her experience with migraine, not only in general life, but also in the workplace, because you can imagine being a presenter on news with the studio lights coming down. It's not exactly the most migraine friendly work environment. And so these two pieces of media were a fantastic contribution to migraine visibility and, a step towards reducing stigma. So it was really wonderful to be a part of these media bits. Next up, speaking of telling our stories, if you would like to get involved in advocacy, we do have an advocacy toolkit available on our website. It's a really helpful resource if you would like to contact your local MP or speak to a journalist. It essentially provides a step-by-step guide on how to do that, as well as letter templates and some other resources. Next up, I just want to thank our event sponsors. So that's AbbVie, the Brain Foundation, Pfizer, and Lundbeck. Thank you so much for supporting this event and making it as amazing as it's been so far. Thank you. So if you're wondering if you are in the right place, who is this webinar for? So this webinar is on the topic of other types of disabling headaches, so non-migraine headache disorders. So this is for anyone who's living with one of these disorders, or if you're a parent, partner, or caregiver to someone living with one of these disorders. Also, if you'd like to connect with others like yourself, and if you want to ask a question to our expert. Speaking of connecting with others and support, I'd encourage anyone who is looking for a space to talk about their experiences to join our Migraine Headache Australia support group. It's a really welcoming community and a very active group. So if you've been looking for somewhere to share and talk about your experiences, it's a great place to start. Now I'd like to introduce our speaker for tonight, Dr. Katherine Spira. Dr. Spira is a general neurologist and headache specialist, and she's the director of Spira Neurology, which is a private clinic based in Bondi Junction in Sydney. And she's also an Honorary Medical Officer at the Prince of Wales Hospital. Dr. Spira's research interests are in migraine and the eye, and she collaborates with a team at the School of Optometry and Vision Sciences and also the Prince of Wales Hospital Clinical School at UNSW. And she's passionate about medical education and regularly works with doctor, allied health, and patient groups in this capacity. So thank you, Dr. Spira, for being with us tonight. It's great to have you here. A bit about me, if you weren't here last night, my name is Nick Grundy and I'll be your host tonight. I'm the Grants Program Manager and Digital Lead at the Brain Foundation and Migraine and Headache Australia. I write a lot of our website articles and newsletters, and I also look after the administrative side of our research grants program, which is so exciting to see, all of the upcoming research projects coming in. So yeah, that's what I do here. And we also have here tonight Carl Cincinnato moderating. So you'll see him in the chat as Carl Cincinnato moderator. I'm sure many of you would know Carl by now, but if you don't, Carl is the director of Migraine and Headache Australia. He lives with migraine and he's a passionate advocate both in Australia and also internationally. So you'll see him in the chat. And without any further ado, I'll let Dr. Spira start her presentation.
Hi, my name's Katherine Spira. I'll be speaking to you today about the other types of disabling headaches. So, what is a headache when it's not a migraine and when it's not a tension type headache? And I just want to say it's lovely to be here. It's lovely to meet all of you. I'm really grateful to Migraine Headache Australia for inviting me to speak today. And that's because I really believe that it's so important to empower patients and give them the tools that they need to manage their own disease. And that's what I like to do as a neurologist. And I always value opportunities to improve people's understanding of headache in the community, especially patients. So I feel really quite lucky to be here today. So let's talk about headache. So probably everyone here suffers from one of these types of headache. There's the sort of dull, bland, both-sided tension type headache. And there's the migraine, which can be on one or both sides of your head, swap sides between attacks, associated with light, sound, and smell sensitivity, can be very severely painful. And for some patients can have very significant other neurological issues, including aura. And we've all heard of them, we all know them and love them, and they affect, unfortunately, the majority of people who have headache disorders in Australia. But then what about the other guys? So there are actually a range of extremely rare and interesting and cool and crazy and painful and horrible to live with headache disorders out there that you may never have heard of, or maybe you have one of them and that's why you've come today. Or maybe you've had a headache that's been treated for years, but you're not getting anywhere. And maybe you'll recognize one of the headaches in this talk as being your headache, and you'll realize that you're not getting better because it's actually not a migraine. It's amazing. Even after I correct the diagnosis, sometimes my patients keep calling them my migraines because they've just been calling them that for so long. And of course, the rarer your headache is, the longer it's going to take a doctor to diagnose it, the more people you're likely to meet along the way. Occasionally, a GP will just perfectly diagnose a super rare headache, and I think it's amazing. I get really excited when that happens. But it takes time sometimes. It takes opinions and different people to get to the bottom of it. So why are the other headaches important? I mean, they keep my life very interesting, but I also find migraine interesting because it's just me. But they're special. They have different treatment. They are their own entities, and they are as complicated and as diverse as any other type of headache that you can get. There's also, the opportunity to help people, because if someone's not getting better, maybe it's because it's not migraine. And that is a really great thing if you see somebody who's been treated for the wrong disease for a long time and you can make that diagnosis. And I think as a patient, having the right diagnosis and understanding what you have is so, so great. Then you've also got I've got patients I treat and they only get half better, because, I might take away their daytime headaches, but they've still got this headache that's waking them up every night. It's driving them nuts and they can't sleep. Well, that's because once you treat the majority of the headache, it unmasks the rare headache that's hiding behind it. And you can make that person 100% better. You might, get rid of 80% of the headaches the first time, and then you can get rid of the rest, the 20%, by diagnosing the underlying rare headache that didn't respond to the treatment because it's not a migraine. And then, of course, there's safety. So headaches that aren't really typical for migraine often are not migraine because they indicate that there's something else wrong with the person. And if you can get in and manage an unrelated disease that gets rid of the headache, or if you can discover something that's life-threatening and treat it and get rid of it, that is a really, important discovery. So this is why I care about them. It's why I think everyone should care about them. And there are people out there suffering from common diseases and people suffering from rare diseases, but they're suffering and they need help. So that's why I think they're important. And we've got a lot of different types of headaches. Actually, there are about 400 different headache disorders. And when you consider we spend most of our time talking about two, that's a lot of headache disorders that really don't get discussed often. And I'm going to be talking about some of them today because I think that it's helpful to know about them. How does a neurologist sort through the headache disorders? Well, we have Cephalgia, which is our journal, and starting back in 1988, a group of neurologists from all over the world sat down and tried to work out how to define the different types of known headache. They collected all the different kinds. They decided which ones, a lot of names given to one headache, and they named that one headache, and they made diagnostic criteria for them all. And this is actually step one. It's ground zero for evaluating a headache patient, is knowing what kind of headache they have. So there are headaches in here that I have seen, a handful of times. There are headaches in here that I've seen once in my career. There are headaches in here that I've seen never, but I've read about them. And then when the person comes in, I think, oh, I went to a conference and they talked about someone with this headache. I think that it's this. So because I can't keep 400 different headaches in my head and everything about a range of neurological conditions that aren't headache as well, of which there are thousands, I like to have this reference to go to. And these days, this classification of headache disorders is actually online, and we can look up, it's arranged really well so that we can look up what we're looking for, even if it's something really weird that we barely know about, or if it sounds similar to something we know of, we can find the specific type of headache that we're looking for, even if we've never even heard of it before. So we sort out the International Classification of Headache Disorders into these three main categories. There are primary headaches. These are headaches that are happening just because they're their own disease. They don't happen because of any particular other process that's going on. Sure, if you have migraines, you might have triggers, and you might find if you skip a meal or you didn't sleep properly or you're having stress, their headaches are worse. But if you couldn't have a migraine in the first place, you wouldn't be able to get migraines from those triggers. So migraine is its own disease, it's its own process. And yeah, you can look at triggers all you like, but if you treat the migraine, you won't have so many problems and you won't have to have such a restricted lifestyle. So all of those headaches that happen just because there's a physiology thing. It's not something you can see on a scan, but there's a physiological reason for it. And they just happen because some part of your biochemistry is not working the way it should be. That's called primary. That's a headache that's happening because of the headache. It's primarily there because it's a headache. Then you got secondary headache. Secondary headache is a lot of different things. It's any headache that's happening not just because it's a headache. So an example would be a headache that's happening because you've got meningitis, or a headache that's happening because you have a tumor, or a headache. So it's a headache that's happening for some other reason. And there are actually really important clues when I'm talking to a patient that will give away those headaches. So I always have to be looking for them. And I'm going to share some of that thinking with you and how we do that in real time. Just to explain what the secondary headaches can be. And then there are facial pains. So facial pains can be either primary, so they can either happen because they just do, or they can be secondary. So they can be something that follows on from surgery or trauma. They can be something that happens because of a nerve contacting an artery somewhere in the head, or because there's scar tissue near a nerve, or because there's a tooth abscess. So these are ones where we always have to do lots of investigations to try and work out what is causing it. So if we then go and we look at what kind of diseases are underlying these, so of course primary headache, tension type headache, and migraine, but there are other weird, wonderful primary headaches that you've probably never heard of, or maybe you have. A lot of people have heard of something called cluster headache. That's one of the trigeminal autonomic cephalgias. And I'll be teaching you a bit about these headaches, because to understand them, you have to understand a bit about the nerves in the head, and it's cool and it's interesting to understand that, especially as a headache sufferer. A lot of things about your own headache might make more sense after we chat about this other type of headache, even if you have migraine or you have tension type headache. So there are also some other weird, wonderful ones that I'll just chuck into the talk for good measure. Then we've got secondary headaches. So these can arise from a whole range of reasons, but within the skull, some reasons that can happen are the pressure in the fluid around the brain either being too high or too low, tumors that could be pressing on the brain or obstructing the flow of fluid around the brain, or aneurysms that are distortions of blood vessels that can be dangerous under certain circumstances, inflammation of vessels, inflammation of the coverings of the brain, and infection. So infection can, take a range of different forms. It can cause infection of the brain, infection of the tissues around the brain, and infections of the skull and other structures. So outside the brain box that the brain sits in, there you've got your eyes, your ears, your sinuses, teeth, and neck, and these structures can all refer pain to the head. And there are certain patterns that creates that a headache specialist will recognize and go, oh, that's coming from your neck, or you probably have this, we need to get your eyes, the pressure check for your eyes, because I think this could be glaucoma. So there are things that give us little clues about that. And then the facial pains, as I explained, can happen for different reasons, but they fall vaguely into cranial neuralgias and other atypical facial pains. I'll be talking about the cranial neuralgias as well, again, to explain how the nerves of the head work, because I think it's informative for all headache patients to understand that, whether or not you have a neuralgia. So that's what the talk will be about, looking at the red flags for secondary headache and looking at cranial neuralgias and trigeminal autonomic cathalgias and other weird little headaches. So we'll go through all those topics in that order. And without further ado, let's jump right in. So we're going to talk about secondary headaches now, and we're going to talk about how a neurologist works out whether they need to be worried about a patient. And by worried, I don't mean, sometimes you hear something you're genuinely thinking, wow, like I need this person to have a scan today, or I need to put this person in the hospital. But more often than not, it's just I need to do some tests to make sure that there's nothing serious going on. We're going to do an MRI, or we're going to do a CT angiogram or something like that. So looking at this, there's an acronym that we use. It's SNOOP 4P. I actually add a fifth P for pregnancy, just because pregnancy has its own unique physiology and can give rise to secondary headaches of different kinds. So the S in SNOOP is for systemic. So systemic in medicine just means something that affects your whole system. So that's stuff like symptoms like fever, chills, muscle aches, and weight loss that can indicate either an infection or a cancer process that's serious. And so if a patient's talking to me and they've had fever and headache, or they've had weight loss and headache, I need to really be thinking about excluding those kinds of things with scans. Then there's N, which is for neurological symptoms. So obviously headache is a neurological symptom, but it's about what friends the headache has. So if the headache moves in, but it's also got a flatmate, which involves weakness down one side of the body, or seizures, or something like that, I would be thinking, could this be a headache that's there because a person's having or had a stroke that's been undiagnosed? Could there be, some other issue, again, cancer and tumors creating other brain problems? The first O is for older age. So my father always used to say, he was also a headache specialist, we used to work together. He would always say no one opens their headache bank account at the age of 50. And that's not really true. There are plenty of women in my practice who got migraine at menopause and it's intractable and difficult to treat, and there's nothing else wrong with them other than migraine. But I have scanned every single one of them because there is a risk that I could have missed something. They usually get blood tests and scans from me before I'm willing to treat them at all, because I need to make sure that we are actually dealing with migraine and we're not dealing with inflammation. So there are certain types of inflammatory headaches that happen in that age group. Then the next O is for onset, and I want to talk to you about that in its own area, because a headache that comes out of nowhere is the worst thing that's ever happened to you, and happens in seconds, is a medical emergency, and I don't want you to forget it, so I want to remind you again after. Another P is papilledema, which is something that a neurologist can see when they look in the back of your eyes. And this could indicate that the pressure around your brain has increased. And this can be either because of a tumor or a disease called idiopathic intracranial hypertension, which is a really interesting disease as well. Positional, most migraine will actually get worse if you bend over or you squat or stoop. But there are certain types of precipitating maneuvers like that can indicate that you have high pressure in the head or that you have low pressure in the head. So if you get better when you're lying flat and instantly you sit up and your headache starts sort of ramping up, that could be a sign of having low pressure in the brain, in the fluid around the brain. There's precipitated by Valsalva maneuver, which is things like breath holding, straining at stool on the toilet, cough, and that can sometimes indicate increased pressure, but it usually doesn't. And then there's progressive headaches. So that's somebody who, maybe they were in a pretty regular pattern with their migraines and suddenly their headache is just there every day and it's getting worse over time. Or somebody that's never had headache and starts waking up every morning with a headache. I'd be worried about really anything in that situation, but tumor would be one thing that I would want to exclude with a scan. I'll already have an idea after I examine the patient at the first consultation whether I'm worried about tumor or some other really serious diagnosis. And most of the time when I'm ordering the scan, I tell the patient the truth, which is that I'm doing it just to be careful. To make sure it's not one of these things. But I think anyone that's got any of these flags needs to have investigations or be very, very closely monitored. So I want to talk to you about thunderclap headache because it's a medical emergency, and I think it would be really irresponsible for me to give a talk about headaches that can be dangerous and not talk about it. So when you have a headache that goes out of absolutely not to being the worst pain you've ever experienced, you may be a migraine patient. You may be used to having headaches all the time, but if you know that this headache is unlike any other headache you've ever had, you should just go straight to emergency because these headaches can be a sign of a ruptured brain aneurysm, which I think the word aneurysm just strikes fear into every human. You don't need to go to medical school for that. But this is a really serious condition, and if you get in and they find the aneurysm and they treat it, you don't necessarily have to, have really significant medical issues and or die. You can actually live. So it's worth getting checked out. And if a lot of these headaches are not that. So there's another common cause, but still needs neurological review. And you have to go to emergency to find out that you don't have a bleed in your brain as step number one. Step number two, we can figure out what else it is. So just a reminder, worst headache of your life, unlike any other headache you've experienced, comes out of nowhere, 0 to 100 in seconds, worst pain that you've ever known. Don't think about it. Just go. Just get someone to drive you or call an ambulance. So again, these are the flags of dangerous headaches, but a lot of people have these things, some of these things without having a serious underlying cause. So let's talk about neuralgias. So neuralgias are cool because they're an opportunity for me to share with you my knowledge about the anatomy of the head and how the nerves in the head work, which I don't know. I love people. I love patients and I love helping people get better. That's my favorite thing. But of course, I also love science and I love medicine. So thanks for indulging me and taking a stroll down the garden path. So with neuralgias, they are basically pains that arise from bits of the head and the nerves of the head and neck firing off abnormally, and this can happen for a variety of different reasons, which we'll talk about in a second. But it causes this characteristic sharp electrical-like pain that's very severe, and it can be in the distribution of any of the nerves. So here I've shown you, if you look at the pink picture, these are the pink part of the first picture, and this picture is taken from the University of Dundee Medical School. So the first part of the picture shows you the 3 divisions of the trigeminal nerve. This is the main nerve that controls a lot of things that happen on the head, and we'll be talking about it again when we come to talk about the trigeminal autonomic cathargas. So you can get in one division of this nerve, these recurrent sharp shooting pains. And shown on here are some other places on the head where you can also get this. So the greater occipital nerve is another common one. And there's a branch as well of the mandibular division of the trigeminal nerve that can cause something called auriculotemporal neuralgia, which involves the ear and the forehead. And these are, there are so characteristic patterns that these fall into. Now, aside from the pain sensing nerves that are on the surface, there are also nerves within the head that control other functions but can cause pain in different ways. So I've put just a picture of the glossopharyngeal nerve, which controls swallowing and can give you, sharp pains as a result of swallow. So a neurologist will be able to, particularly a headache specialist, will be able to recognize the pattern of where these pains are arising, the things that are causing them, and diagnose you with a neuralgia. So neuralgias can arise for a variety of reasons. So sometimes you can have, people who have a normal anatomy, but maybe their trigeminal nerve origin is just really close to an artery near the brainstem exit point, and just one day that artery starts actually squashing the nerve, and every time it's throbbing away, the nerve is sort of firing off electrical pains in the face. So it's not that there's something, desperately wrong with how that person's put together. It's just that we all have things in slightly different positions and different places, and it's causing a problem. Then there are a lot of cases where we just don't know why it's happened to the person, but we know the pattern of the neuralgia. We can diagnose it pretty confidently. Having previously had like a head or facial injury, or can also cause scar tissue to form, which can squash nerves as they're squeezing through, between layers of tissue to get to the skin. And so trauma and scarring is particularly a cause of auriculotemporal neuralgia. It's not necessarily scarring that you can see on the outside of the person, but they'll remember, oh yeah, I had a really bad bump to that area of my head many years ago. I haven't had any problems since, but it's there. And then there's also nerve invasion and compression, which can happen from tumors, so cancer processes, but also there are certain rheumatological disorders that cause, different deposits of things in nerves. And so, if I've got someone who's having neuralgia, or like a neuralgia-like pain, but they've got not only the pain, but also sensation loss in the area, they've got a history of having skin cancer removed from the skin nearby, I would be, really wanting to make sure that those nerves are okay, that there's nothing going on. And so it's kind of, very important to get this right. Then we've got weird and rare. So I'm going to talk to you a bit more about the trigeminal nerve, because the first types of headache we're talking about is the trigeminal autonomic cathargas, of which cluster headache is the most common. There's also a type of headache called hypnic headache, which is not very common but interesting, and often goes in older women with migraine. They will often also have hypnic headache. Not often, rarely, but I see it quite a bit, and it's just interesting to me. I think the day I put this part of the talk together, I'd just seen a couple of people with it. And then there are these little small headaches, which I'll mention to you. They're kind of interesting, and they often also will happen in people with migraine. So the trigeminal autonomic cathargas are their own world of really interesting physiology. And you'll see that, I've put the photo from before, which is, will just remind you of the areas of the face and head that are supplied by the trigeminal nerve. The trigeminal nerve also, incidentally, super important in migraine. Pretty much all the headaches involve trigeminal nerve physiological change in how the nerve is functioning. So it's pretty important. And the interesting thing is it's not just doing the skin. So as you can see in the diagram, which has a lot of the different branches of the trigeminal nerve illustrated, that nerve is supplying the surface of the eye, particularly the cornea, has the highest concentration of nerve endings, sensory nerve endings for this nerve. You've got it's supplying the teeth, it's supplying the sinuses. So all that sensation is coming into the nerve. But then it's got functions that don't have anything to do with sensation. It's also telling your eyes how much tearing to do. It's telling your salivary glands how much saliva to make. It's telling your skin how, if you've ever blushed when someone's embarrassed you or you have a crush on someone or something, it's your trigeminal nerve that's making you do it. It's supplying your skin and telling your skin how dilated the blood vessels should be. It's telling your face how much to sweat. So it's doing all of these autonomic, which is just neurologist for automatic functions, without you even knowing or thinking about it. So the trigeminal nerve has all these autonomic functions, and in the trigeminal autonomic cathalgias, which just means trigeminal automatic nerve system, headache, the headache is combined with dysfunction of these functions that the autonomic trigeminal nerve does. So there are a collection of unusual, rare headaches. I mean, to give you an idea, the most common of these is cluster headache. It's only 1% of all headache patients get cluster. But they sort of fall on a spectrum. And on one end of the spectrum are headaches that happen very, very frequently. I'm talking, you can get 50 to 100 in a day, all the way to a headache that happens all day, every day, never stops once it starts, or, can remit for periods of time. But, when it's there, it's there. So you've got these really short headaches, like these Sunkt and Suna. These are headaches that happen around the eye, one of which involves a lot of tearing. You can get sort of just like, very frequent, very brief episodes coming and going through the day, and they're very disabling. All of these headaches are really painful. They're horrible, horrible, horrible headaches. So, yeah, you can get that sort of thing. You can get paroxysmal hemicrania, where the episodes are sort of longer than that, involving half the head. So the other important thing about these headaches is that they are totally side-locked to one half of your head. If you get it, you will get it on the same side of the head. Every single headache that you have will be there. It's not ever going to cross sides. There are extremely rare exceptions to this that I've seen, but they are, totally side locked to one side of the head, and you'll get terrible pain along with sweating, facial flushing, not all, but some of these things, sinus congestion, tearing, the pupil constricting on your eye, the lid coming over your eye. So they look weird. And if a patient takes a selfie during a headache, you really can see what's going on there. So just to talk to you about cluster, which is the most common of these headaches, it's absolutely excruciating pain. The patient, rather than a migraine where they want to lie down in a dark room and no one to bother them, they are agitated. They're pacing the floor, they're rocking. There are actually, unfortunately, YouTube videos showing people having cluster headache, but they've helped to really raise awareness of the condition. And it looks like someone's actually attacking and like murdering this person. It just looks terrible. They are rhythmic, so they occur at fixed times of day. It's also called alarm clock headache. So typically, patient goes to sleep within the first hour that they fell asleep, they've had their first headache. It lasts around 45 minutes. It's absolutely excruciating. Towards the end of the cluster, they're afraid to go to sleep, but they're also completely exhausted. And they may have many others before they wake up the next morning or before they're ready to leave the house. They'll have some of them will also have some attacks during the day, but they'll only have these in clusters lasting about 12 weeks. They happen during particular seasons of the year. And the northern and southern hemisphere, the majority of patients cluster in a particular season, which is really interesting. And also a lot of the patients smoke and have a lot of trouble quitting smoking. I don't know we're trying to understand that as well, but it's a biological thing. And then so that's cluster, but they're all kind of, each of those headaches are super rare, super interesting, and their own kind of little universe of, things that you need to know to treat them properly. And then you've got your other weird and wonderful headache. This is just like a last minute plug for a few weird, rare things. So there's Hypnic headache, which is this sort of terrible pain, usually in the top of the head. But I do have patients that just have it on one side and just wakes sort of the typical patient is a woman in her 60s and she'll just wake up with this terrible pain in the top of her head, and it will take a while to go. It's also associated with agitation, really rare, but I see it sometimes, often can happen in migraine patients. There are also ice pick headaches. You can see the picture I put there. And so it's just that like stabbing, you'll get like a stab or a few stabs and, within 30 seconds it's gone. And it might only happen occasionally. Don't worry about it, by the way. It's not anything to worry about. It commonly is in patients who have other types of headache disorders. So that's just something to know about. And then there's nummular headache. Nummular just means coin-like. And it's sort of like a little circle. It just feels like it's boring into the patient's head in a certain spot. These all have their own cool treatments. They're all their own interesting kind of headaches. We don't understand all of them because they're so rare and there's not heaps of research into some of them. Others get more. But I find them fascinating. Anyway. Thank you very much. It was such a pleasure to speak with you all, and I'm really looking forward to the Q&A. Thank you.
Thank you so much for that presentation, Catherine. That was fantastic. So now to get into the Q&A, we got so many fantastic questions coming through, so we'll try and get to as many of them as possible. So up first, we have a question from Valentina. And she wants to know, how can we understand what type of headache we have, and can it change over the years or combine with other types of headache? And I think you touched on that a little bit, but maybe just expanding on, how we can understand that.
Sure. So I think that the main thing is that you need to be speaking to someone that knows about headaches to help you. So I wouldn't really have any idea if I had an abdominal pain. Well, I have some idea, but I don't have the best idea of what's causing it. So it's helpful to have a doctor that's interested in headache to bounce things off. There's also a lot of information, and I often actually direct people to the migraine and the Headache and Migraine Australia website because it's so good, and there are sort of regularly updated articles there that can really help you to figure it out and get a bit of a feeling of self-efficacy around that as well. But the main things are that when I'm talking to someone, I'm looking for clues in the story that they're telling me about their headache. So I'll ask them to go through a typical headache, or how often are you getting these? Do they happening at particular times of the month or the year? And from that, I'll build up a bit of a picture of the headaches. So that's how you figure it out. And then, sorry, it was such a good question. There are a few parts to it. So what was there anything else to that?
So about the headache kind of evolving over the years or combining with other headaches.
Yeah, so absolutely. So a lot of headache disorders are lifelong. So, especially things like migraine. And then, as I said in the talk, I've had that particular day that I recorded the talk, I had actually seen two women who had Hypnic headache. Now, they wouldn't have had Hypnic headache when they were 20, and they'd had migraine since they were, teenagers. So they got Hypnic headache, in their 60s, and that became an issue. So their migraines actually got better with age, but then they got a different problem that was worse. So, well, worse at that time. So the diagnosis can change. And also a lot of migraine sufferers will get things like Hypnic headache or sensitivity of the skin to touch and things like that associated with exacerbations in their condition as well. So headaches change over time. And the other thing is that I always, when I'm talking to emergency doctors about evaluating headache in the emergency department, I don't want them to see someone that's had migraine and then comes in with a thunderclap headache and not take the thunderclap headache seriously. I always tell them, if someone with a migraine comes in and they say, this is the worst headache of my life, you have to take that seriously. It might just be a migraine, but it might not. So, absolutely, you can have multiple diagnoses coexisting in one patient, and over a lifetime, the mix of what's actually bothering the patient will change.
Great, thank you. And next we have a question from Fiona, and she's wondering what the best treatment is for occipital area headaches. And there were a couple of other people I saw also asking about occipital neuralgia. Yeah, is there any good treatments for it?
Yeah, there are some great treatments. So, occipital neuralgia is one of those cranial neuralgias. There's a nerve that comes off the top of the spine at C2. It goes up on the back of the head and it squeezes through little bits of tissue around here. It's an interesting nerve, the greater occipital nerve, because once it goes into the head, it actually supplies the coverings of the brain with sensation, and it has an important role in pain generation in migraine and cluster headache. What happens in occipital neuralgia is that the nerve gets, sorry, my office. The occipital nerve gets squashed as it's passing between two layers of tissue, and it can get quite tight there. Sometimes if someone's had sort of knocks to the back of the head, they can have a bit of scar tissue there, but it can happen for absolutely no reason as well. Or also the other time I see it is if someone's, been on bed rest in the hospital or something and had something pushing, just been in one position resting on the back of the head. But there are a bunch of reasons and unknown reasons it happens. And you start to get sort of stabbing pain coming at the back of your head here. Now, anyone who's had cluster headache would know that often there are two focuses of pain, and one of them's over the greater occipital nerve as well, and another one's over the supraorbital nerve at the front of the head. But yeah, anyway, the occipital neuralgia is just from compression of the nerve and that stabbing feeling. And in terms of how we treat it, first of all, the diagnosis is usually made just on the basis of the patient's complaint. I normally also test the sensation at the back of the head in that division of the nerve. It's not always impacted by the presence of the neuralgia, but it might indicate that there's sort of a more severe compression or another lesion there. Anyway, the way we treat it is we give a nerve block to the back of the head. I usually do it under ultrasound guidance. I get a radiologist to do it, but a lot of neurologists just do it according to anatomical landmarks. And you give an injection of cortisone, a type of cortisone mixed with local anesthetic. Usually the patient, the whole back of their head will go numb and you get a bit of a flushing feeling. And that's just the anesthetic kicking in. Once the anesthetic wears off, it takes a few days for the steroid to actually produce an improvement in the discomfort for the patient, because the anti-inflammatory effects take time to work. But then there should be relief. Now, sometimes the occipital nerve compression is so severe that the block doesn't work. Sometimes we repeat the block just to see. But I have had to refer some patients to have the nerve decompressed by a neurosurgeon. Not all neurosurgeons can do this, but there are specific surgeons that are trained in peripheral nerve surgery and they can do this. But you've got to be pretty, to do that, I had to be very, very confident in my diagnosis because this patient didn't, the patients often don't respond to that, or they'll have a very modest improvement with the injection and you'll need to sort of take it further.
Okay, yeah. I did think, I swear I saw someone in the chat or Q&A mentioning is Botox ever used for occipital neuralgia treatment? Like, is that something that's effective or?
So we do use Botox to treat neuralgia sometimes. And I guess the occipital nerve is not a bad place to do it because you're not going to give someone a wonky face from injecting the back of the head. So it's kind of good to do that. You can do it, but it's not as mainstream and sort of first line of treatment as giving a nerve block.
Right.
But you can. So for some reason, if someone's got like a trigger zone for a neuralgia, such as, a difficult to treat trigeminal neuralgia or a difficult to treat occipital neuralgia, you can, and I actually use Botox sometimes for other localized headaches. So someone's getting ice pick pains in a very specific part of their head. You can do some little injections in that area of Botox, and it can actually reduce how pain sensitizing that region is. But it doesn't always. It's something that people do and they talk about, but at conferences and things, so it's not something that's as frequently done.
Okay, great, thank you. The next question is from, actually the next few questions are from anonymous attendees, not to worry. So the next question is, someone who suffers from cervicogenic headaches, and they're wondering what is the best approach for these types of headaches, like, for example, from neck issues like spondylosis, arthritis, etc.
Okay, so the important thing to know is that when people use the term cervicogenic, a neurologist means one thing, a physiotherapist needs another thing, a chiropractor needs another thing. So it's quite a loaded term. When I'm using that term as a neurologist, what I mean is that there's a specific structure that I've identified in the spine that is causing headache. And the most common one that I see is usually a facet joint arthritis in the neck that can cause quite an acute referred pain. The pattern of and it's a specific structure in the neck. So I'm talking about a headache as well that is only on one side of the head because it has to relate to the side that the spinal issue is on as well. So I'm talking about things that are coming from the cervical spine when I say cervicogenic, and not from the musculature around the spine. So yeah, that's what I mean. There are lots of different structures in the neck that can cause referred pain to the head, and I would classify this headaches differently. Anyway, what I do is I like to identify the specific structure and I like to treat the specific structure. So if it's a facet joint arthritis, for example, I will order a localized injection of the facet joint with steroid, which will reduce the inflammation in that spot. Again, similar time course to giving an occipital nerve block. To identify the joint, sometimes it's enough to do an MRI or something, but sometimes I will need to do a bone scan to actually, or CT SPECT scan, and that will specifically highlight the metabolic activity in the single joint that I'm interested in. So that's how I go about managing that scenario. If I think that there's a different structure in the neck that's causing the headache, it's not at the cervical spine, it's not a specific joint, then that's a bit of a different question. And also often the joints at the very top of the spine, which you can't really inject because there are blood vessels and all sorts of dangerous stuff that you could hit with a needle. So in those sorts of situations, sometimes I use a soft collar on the patient and I give them non-steroidal anti-inflammatory drugs for a period of time to just generally calm down the inflammation in the area. The neck and head have a very interesting relationship in terms of muscular activation. So when you activate the trigeminal complex, in the brain, you've got a pain map of your whole body. And in that pain map, the head and the neck are one structure. What that means is that if you have migraine, for example, you can, sometimes the first sign of that is actually activation of muscles in the neck. So there's a whole lot of overlap between neck issues causing headache and headache causing neck issues. So it can get very confusing. And I think that's why there are so many different ways that different people describe headache and then like arising from the neck or attribute headache to the neck when actually the neck problem is attributable to the headache. So it's quite complicated. There's a lot of turf wars in there, but yeah, that's my sort of basic.
Yeah, okay. I guess like for a lot of secondary headaches, it'd be very much just trying to figure out exactly what that underlying mechanism is to treat it. Yeah.
Yeah.
So the next question is someone asking what this isn't necessarily related to headache, but they're wondering if you know anything about brain fog treatments, like if there's any medications, prescription or otherwise, or even like supplements, herbal treatments that can help with brain fog. I mean, it's something that people with headache disorders, I think, struggle with a lot from what I've heard. So, yeah.
I wish. That's my answer to that question. Brain fog is super common, especially with migraine sufferers. It is a really rough symptom and it's difficult to treat. I say the first step, and you've probably already done this, is to go back to basics and look at things like you've got to look at like lifestyle factors. For some people, particularly people that have been burnt out at work previously, I often will see brain fog is really a symptom of them. You know, they've gone sometimes years ignoring things like I'm hungry or I need to go to the toilet or things like that, like basic physiological cues that their body's giving them. And so instead of getting those basic things, they start getting brain fog instead. they don't notice when they're starting to get hungry, but they'll notice 2 hours later that they're feeling really foggy, but that's actually hunger. So sometimes it's very individual, basically, but I normally go through all that lifestyle factor stuff with patients, and I try and tease out if there's anything that we can modify that we can take basic steps on to make it better. But there are a lot of people living with very significant levels of brain fog that have done all that work and haven't really found a way of dealing with it. I actually had a lot of brain fog while I was recording that that talk
Oh,
about very bad migraine in the days before it. So yeah, but I think also I mean, I usually don't have brain fog though, so I feel very lucky about that. But the 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 thing is that it's also about having a go. So sometimes, like, if I'm having a day like that, I actually just have to keep going. And I think most people with brain fog do that. But yeah, there's no really good answer to that question other than, doing basic check-ins about hydration, sleep, etc., diet. But there's not great treatment for it. I wish I had a pill for that, but I don't recommend anything. A lot of our pills can make it worse. Yeah.
Yeah. I guess like a lot of things, it's not satisfying, but it is so important, like to, take care of those basics. The next question is someone asking if any other types of headache cause auras, or is it just migraine?
That's a good question. Some of the secondary headaches cause things that look like aura but are not aura. So there are weird things. So if you lose quite a bit of vision, you'll actually you can start seeing things. So the brain sort of substitutes in things that you're seeing in areas of vision that you might be missing. So sometimes if someone's had a particular type of stroke, which causes cortical blindness, they can see shapes and colors. Sometimes they can see completely formed visual hallucinations as well. Or people, often there's, people describe cues of people standing there, but for some people it's colors and shapes and things that people might see in visual aura. Also, there can, in one type of secondary headache caused by inflammation called temporal arteritis, vision is affected. So, and you usually get visual loss, but you can get positive visual phenomena as well. So, and also there are cases where you can get very tiny little blood clots passing over the surface of the brain that trigger something identical to visual aura. So it's really rare. And I would say that if it's happening with a headache disorder that's established, that's operating in a particular pattern, it's probably migraine. But there are non-headache disorders or things that can cause sort of secondary headaches that have visual aura associated with them.
Okay, great. Thank you. The next question is actually asking about a research update from Jane. She asked, Dr. Spira, was there any results on the dry eye research at Prince of Wales for migraine?
Yes, thank you. That's lovely of you to ask. So where we're up to on that is I've got a wonderful PhD student called Amelina Mohammed Isa, and she's been taking care of the project. So first of all, the dry eye trial, I think it was actually an issue with study design, and also we didn't follow people for a very long time. But I wasn't that convinced that the trial worked. Do I have patients who use dry eye treatment and think it's helped their headaches? Yes, but there aren't huge numbers of them. So it's about the study's actually going to be published shortly, but it's not that exciting. But we've found some really interesting things by studying the corneas of the patients in that study, and also we've looked at chronic migraine patients, episodic migraine patients, and normals, and compared the anatomy of their corneal nerves. What we found is that there are specific changes to the nerve endings on the cornea. So these are endings of the trigeminal nerve that we can just see really easily because they're embedded in a clear structure. So we can put a microscope on the surface of the eye and we can look at those nerve endings. And what we found is that when somebody has super high frequency migraine, like a chronic migraine sufferer, there are anatomical changes occurring to their nerve endings. So that's one thing. We already knew that before we did the research. But the interesting thing is when you treat them and they get better, the nerve endings go back to normal. So to me, that says that we have seen that there is a cellular substrate to chronic pain, which is an amazing finding. And that's probably the most exciting outcome of the research so far. We've almost collected enough tear samples on enough patients to analyze the tears for levels of CGRP, which is a really important chemical in migraine. To look at we have a lot of questions we want to ask around the levels of CGRP in the tears, because the tears and the composition of them is governed by the trigeminal nerve and it telling the body how to mix the tears. And we know from other studies that have been done by other people that the levels of these migraine-causing hormones in the tears are the same as the ones that we can collect if we take a sample from the jugular vein. So this is really exciting. That's what we're up to with that. But yeah, the dry eye study, unfortunately, we didn't, I still use my eye drops. I've got them right here next to my screen. But it doesn't seem to help that much. But a lot of patients say that the patients still get an improvement in their eye comfort if they have dry eye and they're using it. It just doesn't seem to help their migraines.
Yeah. Oh, that's great to hear. And it's also, well, not great that it's not helpful, but great to hear the general research update. It actually ties in quite nicely. If anyone missed Dr. Elspeth Hutton's talk on Tuesday on chronic migraine, she spoke a lot about migraine biology, and a lot of your answers just then kind of like flowed on from what she was talking about, which is, always great when there's synergy across the week. I just realized the time. I guess we'll get one last question in quickly. The next question is from Lena, and she's asking if a triptan works for a headache, is this a good indication that it's migraine rather than any other type of headache that you talked about?
Most of the time, yes, but triptans also work on cluster headache. So, they can, if it sounds like a cluster headache and it responds to a triptan, well, I'm not surprised. So, it's a lot of because of where the headaches are coming from and the sort of structures that I was teaching you about tonight, all the chemistry and some of the nerve stuff is similar. So some treatments do work for multiple headaches, but triptans also seem to work for Hypnic headache as well. I wouldn't recommend it as a strategy, but yeah, a lot of my patients before I diagnose it, they would have had an effect from triptans as well.
Oh, that's really interesting to hear. Thank you so much. Well, that's all we have time for tonight, unfortunately. But thank you so much for your fantastic presentation and answering all these questions, Dr. Spira. It was so great to have you here. And everyone, we will have one more session tomorrow morning, which is a recap of the week and also a general Q&A. So you can ask about anything, any questions that didn't get answered so far. So that's 11 a.m. with Dr. Tissa Wicharatney, and we would love to have you there. Thank you so much and have a lovely rest of your night. Bye.